This eHIV review program is presented by DKB Med Radio.
But I think it is an interesting take-home about the fact that long-acting PrEP takes away the number of actions that the individual has to do on a daily basis to protect themselves.
New directions in long-acting ART and long-acting PrEP. Welcome to eHIV Review. The goals have been set. The strategies and roadmaps determined. The tools constantly improved. What's available today? What's coming tomorrow? What does the evidence and expert advice say? To discuss these issues, we're pleased to be joined today by two guests from the Johns Hopkins University School of Medicine in Baltimore. Dr. Ethel Weld, one of our long-serving eHIV review program directors, is an associate professor of medicine from the divisions of clinical pharmacology and infectious disease. And her colleague, Dr. Michael Rose, is an assistant chief of service of the Thayer Firm. For our guest disclosures and additional CME information, please go to our website, ehivreview.org, and select the Volume 9, Issue 12 link. I'm Bob Busker, executive producer of DKB Med's e-literature review video programs. Doctors, thank you both for joining us today.
It's a pleasure to be with you, Bob. Thanks for having me.
Happy to be here.
Our overall learning objective for today's program is to describe the evidence and potential indications for new and emerging ART and PrEP options. The focus of this first part of our conversation is to discuss the features and benefits of an FDA-approved, long-acting complete antiviral regimen for the treatment of HIV in virally suppressed individuals without a history of treatment failure and the evidence behind expanding its use into other populations. So, if you would please, Dr. Weld, start us out in the clinic with a patient scenario.
Sure. So we're going to start by talking about a 39-year-old gentleman. He has GERD and HIV, and he presents to your clinic to reinitiate care after a period during which he had fallen out of care. He recently immigrated to the United States from Uganda, and he has subtype A1 HIV virus. His current CD4 positive T cell count is 240 cells per cubic millimeter, and his HIV viral load is 140,000 copies. His BMI is 29. You test him for hepatitis B, and it's negative. He thinks that a few years ago, he had been taking a regimen back home that included efavirenz and gave him nightmares. And he really reports that he hates swallowing pills and has struggled to take daily pills in the past as they remind him every day of his HIV diagnosis and of the painful circumstances surrounding his seroconversion. He asks you about other treatment options for him and whether he can begin them today.
Doctor, what do you tell him? What are the immediate options for this patient?
Firstly, I would stress to him that there are options. There are many options these days, and that I'd like to be his partner in the journey of identifying the appropriate option for him that works best within his life, and that we can work together to try some of these options and identify the one that is best for him, and that sometimes we don't find that on the first try. We have to try a couple different options. So for treatment options, you could consider as first-line oral antiretroviral treatment, something like bictegravir, TAF, FTC, a fixed-dose combination, or dolutegravir plus a combined combination of TAF and FTC. It's very well tolerated, and again is recommended as first-line in the guidelines. But these pills actually might be discovered within the household and increase the risk of inadvertent disclosure of his HIV status. And it sounds like he really is dealing with quite a bit of internalized stigma around this. And he describes a circumstance where his household co-inhabitants may not know about his diagnosis. So inadvertent disclosure of status is one of the risks that can adhere to taking pills. There is also an FDA-approved long-acting complete regimen. So it's composed of two drugs, uh, cabotegravir, which is an integrase strand transfer inhibitor, and rilpivirine, which is a non-nucleoside reverse transcriptase inhibitor. And it was recently shown in the Latitude trial to provide better virologic suppression than standard oral ART for people like him who struggle with adherence to daily pills, which you already know he has that struggle because he's telling you he does.
Give us a brief synopsis of Latitude, if you would, please, and what the investigators found.
And so the Latitude study that we were discussing was a study that looked at long-acting injectables in people with adherence difficulties who were unable to suppress despite being prescribed oral ART. It required individuals to first attain viral suppression on an oral ART regimen. So that was quite challenging because these are already people who are telling you they have difficulty adhering to an oral ART regimen. This period was supported by cash incentives for every incremental decrease in viral load. And if they did suppress successfully, they would get randomized to either receiving the injectable or staying on oral ART.
Well, thank you, Doctor. What else should clinicians know about this study's findings?
Yeah, so some have raised questions about whether these agents will still work in a African or low or middle income country context, particularly in settings where there has been treatment failure on NNRTI-based regimens like efavirenz, which he reports having been on in the past. So there was a concern that there might be hidden resistance to the NNRTIs that would compromise the efficacy of rilpivirine and perhaps increase the risk of virologic failure in these settings where there was widespread rollout of NNRTIs and unclear, sometimes history of treatment failure in the past. And it's not practicable or really standard in many of those settings to genotype everyone at baseline before starting treatment. So the recently published CARES trial answered this question about whether this regimen is still viable and applicable in low and middle income settings. And it answered it with a resounding yes. So that's been pretty exciting.
Dr. Rose, tell us a little bit about the CARES trial, if you would, please.
So this trial was conducted across 8 sites in Uganda, Kenya, and South Africa. And it was a non-inferiority trial where they simply sought to replicate that this regimen would be as effective as oral ART in the context of those countries. And so they randomized individuals who were suppressed, which is an important piece of context here, that all these individuals coming into the trial were suppressed on their oral ART, and half were switched to rilpivirine and half were continued on their oral ART. And they followed up these individuals at 24 and later 48 weeks to check on their maintenance of viral suppression. And the overwhelming positive news was that individuals in both arms continued to do very well, with over 96% of people being suppressed, and rilpivirine met the pre-specified criteria for being non-inferior to continuing oral ART, just reaffirming that even in contexts that have numerous patients who are very treatment experienced with NNRTIs, that this regimen holds up quite well, at least in the context of suppressed switch.
Yeah, and Mike, I thought one of the really exciting things about that finding was that it was made in the context of a more pragmatic and less tightly controlled trial setting in comparison to the initial trials with cabotegravir and rilpivirine. So that's quite reassuring that its potential rollout in clinical care would be similarly efficacious.
Exactly. I think that's why CARES is so exciting, is less that it answered some really fancy, intricate thing, but it answered a very, very, perhaps one of the most practical real-world questions surrounding this drug is how will it work in real-world situations in sub-Saharan Africa and people who've been exposed to NNRTIs. And it's very reassuring to people practicing in that context that it holds up quite well.
Well, let me ask you, Dr. Rose. In the patient scenario we started out with, you noted his HIV viral subtype was A1. What's the significance of this subtype? Why is it important to know?
Yeah, the reason A1 subtype is pertinent here is that there was a question based on some earlier studies of whether A1 subtype or A6 subtype of HIV-1 could be a risk factor for treatment failure with cabrolpivirine. And reassuringly, 57% of people in the CARES trial had this A1 subtype. And they all seemed to do quite well in the study. There was no big difference seen in that subgroup. And so that way we're able to be, again, reassured that it's reasonable to use cabrolpivirine in individuals with an A1 subtype. People with the A6 subtype are a little less common and are predominantly found in Russia. And there's still some questions about efficacy in that subtype.
Interesting. So in this patient we've been discussing, what other concerns should clinicians have about treating with long-acting cabrolpivirine?
Good question, Bob. I think one thing we always check and think about is our patient's weight when starting this regimen. And while our patient is overweight, his BMI remains below the cutoff we use of 35. That's been found to be associated with higher risk of virologic failure on cabrolpivirine. So he should be okay from that standpoint. And here's another question that the pragmatic design of the CARE study helped provide some reassurance on, is that many of patients in the study were indeed obese, and failure was still very infrequent in the suppress switch population there. Some other considerations is that there are a small but non-zero number of people who do seem to develop new emergent resistance to cabrolpivirine with on-time injection. And less than 1% of the individuals in the CARES trial experience this phenomenon. So it's something that we always talk to our patients about, that there is a very small risk that even if you do everything right, there's a small risk you'll get resistance that develops on this regimen. But we have more data that we can reassure our patients that this risk is low. And those who did in the CARE study have virologic failure actually had resistance mutations at the start of the study, either to cabotegravir or rilpivirine. That wasn't detected as part of the study because of the pragmatic design, in which it's not usual practice in those contexts to always check genotypes before starting therapy. But as a sub-study, they kind of investigated those who had virologic failure, and it looks like there was pre-existing some degree of resistance. Ethel, I know there's also a caveat when we are treating people with high BMI with these injectable regimens about exactly how it is best to administer the drug. Can you share some of the best practices on that front?
Yeah, sure, Mike. So even with the higher BMIs, we do routinely treat people with cabotegravir and rilpivirine who opt for that treatment modality if it makes sense clinically. And the recommendation is just to use a longer 2.5-inch needle when injecting, basically just to get through the subcutaneous fat to the muscle. But it's important to note that this was not done in the CARES trial. A regular length needle was used, and this is the case even despite 22% of the participants having a BMI above 30 kilograms per meter squared, which is how obesity is generally defined. So it was a population that skewed towards the obese BMI range, and still used normal length needles and still had a 96% rate of viral suppression with cabrolpivirine. So that was reassuring. But in the States, if you can get a hold of the 2.5-inch needle, I recommend it for people with the higher BMIs above 35. I guess one other thing, Mike, just to mention is just that we kind of have this association in our heads. He does have reflux disease. So if he needs to take acid suppressing meds like proton pump inhibitors, for example, oral rilpivirine would not be a good option for him because it needs an acidic environment in the stomach to be absorbed. But, and this is a crucial but, that's not the case for intramuscularly injected rilpivirine, which gets absorbed from the gluteal muscle injection site and has no dependence on stomach acid for its absorption. So sometimes, we have in our heads a kind of thing about no rilpivirine with GERD and with the need for acid blocking meds, but that does not hold true for these long-acting injectable formulations.
Thank you, Dr. Weld. Dr. Rose, let me ask you, why is it important to know about his hepatitis B screening?
Well, beyond it being important to know for everybody about their hepatitis B screening, it's especially important when we're thinking about starting individuals on cabrolpivirine, because neither of the agents have efficacy against hepatitis B. So many of our more commonly used oral regimens include tenofovir, lamivudine, emtricitabine, and other agents that have efficacy against Hep B. And so it's important that when we're going to switch individuals from those agents, or we're starting somebody, that we know what their hepatitis B status is, and we're being mindful during that switch. So the specific concerns that arise are the risk of occult Hep B reactivation if you're switching from someone who's on, say, co-formulated bictegravir, tenofovir alafenamide, and emtricitabine, a very common regimen we use here in the States, to a regimen that, like cabrolpivirine, that doesn't include the tenofovir and emtricitabine, is that there's a very small but real risk of severe Hep B reactivation in individuals if you were to make that switch and not know that they had Hep B and HIV co-infection. And so that's really important that you test and monitor those patients during the transition.
One last question for this part of our discussion, Dr. Weld. What can you tell us about other HIV treatment regimens that might be up for approval in the near future?
Yeah, so there's another interesting long-acting two-drug regimen that's oral, so it's a pill, but taken less frequently, that's coming down the pike, and that is once weekly oral islatravir, which is a non-nucleoside reverse transcriptase translocation inhibitor, plus lenacapavir, which is a capsid inhibitor that has been studied most recently as a PrEP agent in the PURPOSE trials as a subcutaneous injection. So this is the oral form of it. And this is kind of interesting because if the re-traumatization that our patient is suffering every time he takes his daily oral meds, which has really led to adherence barriers for him, if that is minimized enough by taking it weekly instead, then that might eventually be an option for him, particularly if he really hates needles and injections and doesn't want to come into the clinic every 2 months or 1 month. And we saw promising phase 2 results, both at CROI and the Glasgow HIV meeting in 2024, and phase 3 results should be available soon for this regimen. So that's exciting.
Doctors, thank you both for this highly informative conversation. Our key learning focus for this part of our program is to discuss the features and benefits of an FDA-approved long-acting complete antiviral regimen for the treatment of HIV in virally suppressed individuals without a history of treatment failure, and the evidence behind expanding its use into other populations. So, summarize for us, Dr. Weld. What are the most important things you want our learners to understand?
Yeah, so I think one important take-home is that current FDA labeling supports the use of long-acting cab and rilpivirine as a complete regimen in individuals with HIV who are virally suppressed, but emerging data also supports its use in non-adherent viremic individuals with a history of treatment failure, provided that they first suppress on oral ART, which was a requirement of the Latitude trial and, of course, de facto of the CARES trial, since it was a trial done in people who were already suppressed at study initiation. I think the second take home is that in that CARES study in an African setting with the possibility of some NNRTI resistance or past treatment failure, long-acting ART with cab and rilpivirine was non-inferior to standard 3-drug oral ART and actually highly efficacious. And then the third take-home is that long-acting ART can still be considered in individuals with obesity, and you may have to do some mitigation measures like using a longer needle, et cetera, but certainly is acceptable regimen in that patient population. The last take home, I think, is that before switching a patient to long-acting ART, it's critical to know their hepatitis B status. So if they do have hepatitis B infection alongside their HIV, then the cabrylpivirine is not a great regimen for them. And they should be on a regimen that includes hepatitis B active agents. And then also that the recommendation is to test for Hep B anti-surface antibody before switching, because if they're negative for that, it's an opportunity to vaccinate them, preferably with the more effective adjuvanted vaccine.
Nice summation, Doctor. And we'll return with Dr. Ethel Weld and Dr. Michael Rose from the Johns Hopkins University School of Medicine in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's eHIV review program. Our guests are Dr. Ethel Weld and Dr. Michael Rose from the Johns Hopkins University School of Medicine in Baltimore. And we've been discussing the evidence and potential indications for new and emerging ART and PrEP options. Let's turn now to PrEP, and our second focus, to describe both the emerging, which in this context means not yet FDA approved, as well as the currently FDA approved long-acting antivirals for the prevention of HIV. So if you would please, Dr. Weld, take us back to the clinic with another patient scenario.
Sure. So we're going to talk this time about a 32-year-old woman who comes to your clinic. She's actually accompanying her husband, who's the 39-year-old man with uncontrolled HIV we discussed in the previous case, and they've recently immigrated from Uganda. She received a negative HIV screening at a recent health fair, and she's interested in whether there's anything that she can do to protect herself from getting HIV within her serodiscordant partnership with her husband, who's HIV positive. She states that they live with many family members, and she's worried that the family members might find out about her husband's HIV status. Currently, she is the only one who knows, and she is interested in getting pregnant, but not until she finishes her degree in 2 years. So she comes to you asking about options for her.
HIV negative herself, with a husband whose HIV is uncontrolled and his status has been kept secret from the extended family they live with to avoid stigma. Plus, she'd like to get pregnant in a couple of years. So what would you offer this woman?
Well, we fortunately are in the good position of having 14 years of experience with oral pre-exposure prophylaxis for HIV, which is extremely safe and well tolerated. And if it's taken as prescribed, so if it's taken correctly, it is close to 99% effective at preventing HIV in both men and women. So TDF-FTC could be an option. That's a combined pill with 2 nucleoside reverse transcriptase inhibitors in it. And that's if her kidney function is okay. TAF-FTC is currently not approved in women because women, at least cisgender women, were not included in the clinical trials leading to its approval, and so cannot play a role here.
So no TAF-FTC, and also I would think if she's seen taking HIV prevention pills or if they're found in her household, that runs the risk of outing her husband's HIV status to the family. So what else could you recommend?
Well, so getting long-acting injectable PrEP, which there is an approved option for, cabotegravir is approved in the U.S. for PrEP, or lenacapavir, which is coming down the pike, but not yet FDA approved for PrEP, would certainly circumvent that concern, as no PrEP pills are in the household and stored in common areas. And instead, the patients just go to the clinic once every 2 months, or in the case of lenacapavir, 6 months to get their shots. So particularly if they're getting their shots in a more general clinic or health center or primary care physician, not one that's really widely known to be an HIV clinic, this can be a fully discrete option that circumvents some of that stigma.
Good solution. Thank you, Dr. Weld. Dr. Rose, now let's talk about her desire to get pregnant. Is it safe for her to get pregnant while on long-acting PrEP, assuming, of course, she opts for that?
Good question, Bob. Interestingly, it is an area that we are getting more and more data. And the reason for that is human nature. So when you enroll thousands of young individuals into a study and follow them for a year or sometimes longer, a substantial subset of them will get pregnant. And when they're pregnant on when individuals get pregnant on long-acting injectables, it's not as easy as just stopping the medicine, as the medicine stays in their body for some period of time, such as is true with cabotegravir. And so if you look at, for example, the HPTN 084 study, the main CAB long-acting PrEP study in cisgender women in sub-Saharan Africa, about 50 times during that study, women became pregnant while receiving long-acting cabopivirine, and that allowed us to gather some real-world data on how these individuals fare. And the good news is when that data was presented in Munich in 2024 at IAS, it was found to be safe and well tolerated for both the women and their babies. No dosing changes were needed. Cabotegravir concentrations did decline slightly as pregnancy stage advanced, but they remained above the protocol specified target concentrations. So overall, reassuring data about safety and efficacy of long-acting injectable PrEP, at least with cabotegravir in pregnant individuals or individuals who become pregnant while on long-acting injectable PrEP.
Yeah, it's really interesting. The fact that the drug cannot really be easily withdrawn and stays in the body in the case of cabotegravir and lenacapavir for over a year has actually opened up the way for these studies to be vanguard adopters of including pregnant women and allowing their continued participation in the studies, because in the study or not, they're still on the drug while pregnant. And so that's actually given us extremely valuable information that we can then give to our patients who are desiring to become pregnant. I think in the future, maybe there will be more data forthcoming. There's a study that's being planned of cabotegravir and rilpivirine in pregnancy for virally suppressed individuals. So that should be coming down the pike soon, and we'll be able to provide our patients with even more information. But the initial information is all reassuring.
Well, thank you, Dr. Weld. Dr. Rose, tell us about lenacapavir. What are some of the things clinicians need to keep in mind about its use?
Great question, Bob. Well, lenacapavir has already been approved and available as a part of HIV treatment in the United States for those who have multi-class resistant HIV, so for individuals who are already infected. But of course, what everybody in the community is most excited about is the recent presentation and publication of the PURPOSE 1 and PURPOSE 2 trials, which investigated whether long-acting lenacapavir given every 26 weeks, so twice a year, was effective as PrEP. And it was found not just to be effective, but profoundly effective with near 100% prevention efficacy compared to baseline incidence of HIV. PURPOSE 1 was done among women, largely in Africa, and then PURPOSE 2 was performed in men who have sex with men and gender diverse individuals internationally. So we have increasing data that that lenacapavir is incredibly effective in a wide array of populations and contexts. So, for example, in PURPOSE 1, the incidence of HIV in lenacapavir was 0. Out of 2,134 individuals who got it. In the arm of that study who got TAF FTC, it was 2 infections per 100 person years. In TDF FTC, it was 1.7 per 100 person years. And the background incidence, since we couldn't randomize people to placebo given the previously demonstrated efficacy of TDF FTC, was 2.41 per 100 person years. And so my question to you, Dr. Weld, is, knowing what you know about both HIV and pharmacology, is, do you think it's something special about the molecule or the mechanism of lenacapavir? Or do you think it's really the old adage of the most effective medicine is the one the patient can afford and can take reliably?
Yeah, thanks, Mike. I think that's a critical question. And as we know, drugs that are not taken don't work. So, it's likely that lenacapavir is not superior to TDF-FTC or TAF-FTC in preventing HIV on a molecule-for-molecule basis, but rather that the people in the oral comparator groups did not take the PrEP every day. And this was actually seen and documented in a sub-study of about 10% of the participants where they measured drug levels of those oral comparator drugs. And they had levels of study drug much lower than would be seen if they were actually taking the drug every day. So we know that for various reasons that some of them really relate to not perceiving themselves to be at risk of HIV. Healthy people who feel well may not want to take drug, and this has been shown repeatedly, particularly in populations in sub-Saharan Africa of women and others. And in this study, I think it confirms that we were studying a drug that we directly administered in one arm, that's the lenacapavir, and we were studying a drug that we asked patients to take in the other arm, that's the oral PrEP options, that we confirmed by PK testing that they did not take. So it's not truly a fair comparison in a way. A fair comparison would have been directly observed therapy with the oral PrEP, but that was wildly impracticable and too difficult to implement and probably much too high cost. But I think it is an interesting take home about the fact that long-acting PrEP takes away the number of actions that the individual has to do on a daily basis to protect themselves.
Assuming that lenacapavir becomes approved for PrEP in the U.S., clinicians are going to need to be aware of the potential interactions with a wide variety of commonly used medications. We don't have the time here to go into a full discussion of the pharmacokinetics, and it's likely that most clinicians won't either. Is there a good workaround?
And the good news is that that our regular interaction checkers already include lenacapavir in them. So we should just be, if we can't memorize things as well as you, we can go there and double check our patient's med list with this med when we're starting it.
Yeah, and I routinely do that when I'm starting new HIV medicines. I go to the Liverpool HIV medicine drug-drug interaction website, which I find extremely helpful and user-friendly, and I plug all the drugs in just to make sure there's not an interaction that I'm not aware of. So I put patients' whole medicine lists in there, and it'll tell you what's contraindicated and what's a relative contraindication and what's completely smooth sailing. So that's a really helpful resource.
When do you expect lenacapavir to become available as PrEP in the U.S.?
So I would expect lenacapavir to become available as PrEP in this country this year, as the new drug application was submitted in December of 2024. We don't yet have much data in pregnancy and lactation, but we'll likely have more information about this in the next few years, as mentioned. And I think, for this lady who in 2 years is done with her schooling and may want to become pregnant and may have access at one time to lenacapavir in the future. If you do have a patient who's on lenacapavir PrEP and does become pregnant, I would strongly encourage you to register that patient with the Antiretroviral Pregnancy Registry, the APR, so that we can, as a community of clinicians and patients, have more information about its use in pregnancy.
What can you tell us about potential new PrEP possibilities for approval in the near future? What's showing promise? Dr. Weld?
Sure. So there are not yet approved options. So in addition to lenacapavir, which as we discussed has been submitted but not yet approved, there are longer acting formulations of cabotegravir that can be dosed as infrequently as every 4 months. So we saw phase 1 data on an ultra long acting formulation dosed every 4 months at CROI 2024. That study also assessed whether an adjuvant of recombinant human hyaluronidase could improve delivery. So when you inject a long-acting drug into the muscle, or actually under the skin, hyaluronin, which is a component of your subdermal layers, forms under the skin and makes a gel. And this product breaks up that gel, allowing you to be able to inject larger injection volumes and allowing the drug to absorb more easily from the subcutaneous space. So the manufacturer of cabotegravir bought this product to try to see if adding it to the drug would be beneficial in increasing absorption, potentially allowing even less frequent dosing intervals, et cetera. But in this phase 1 study that was reported, there were higher rates of injection site reactions. So there was dermal necrosis in one of the participants. And so this approach has been discontinued, in addition to not leading to particularly favorable PK. So those are things I'm interested in and looking forward to seeing more about, because I think the fewer times a year that you have to come in to get your injections, the easier it is to kind of stay on the regimen. There's a lot of pie in the sky stuff coming down the pipeline, but we have to not ignore the fact that we have multiple extremely well established and well tolerated PrEP agents that are approved for current use in this country. And that includes oral TDF-FTC, oral TAF-FTC, though not for people born female, and long-acting CAP. So those are all options that are approved for PrEP use right now that you could offer this woman.
Let's wrap things up now by going back to our key learning focus for this part of our discussion, which is to describe both the emerging as well as the FDA-approved long-acting antivirals for the prevention of HIV. Dr. Rose, what are the key things you want our learners to take back to their practices?
So first and foremost is identifying individuals who would benefit from PrEP and those who would especially benefit from long-acting injectable PrEP, often due to considerations such as in our case, where individuals have reasons such as stigma, disclosure, or difficulties adhering to pills, as we see time and time again, is a major barrier to efficacy. The second is to always remember that TAF-FTC, which we tend to prefer for our treatment regimens, is not FDA approved as PrEP in cisgender women, as cisgender women were not included in initial studies leading to its approval. So important not to default to that medication in that population. Third point is that long-acting lenacapavir, which is able to be dosed just every 26 weeks, has been shown to have almost 100% efficacy compared to background incidence in both cisgender women and nearly 100% efficacy in men who have sex with men and gender diverse individuals, which is very exciting. And the final key learning point is the big reason why that lenacapavir was likely so successful is not so much the molecule itself, but really that adherence is the key for PrEP efficacy. And so long-acting injectable technology offers a way to really improve the amount of time our patients are being covered by PrEP due to barriers and adherence that can arise from a whole number of factors. And that was shown in the pharmacokinetic sub-study of the PURPOSE trials.
From the Johns Hopkins University School of Medicine in Baltimore, Dr. Ethel Weld, Dr. Michael Rose, thank you both for sharing your knowledge and expertise with us in today's eHIV review program.
Thanks so much, Bob. It was really a pleasure. Thanks for having us.
Thanks again.
For eHIV Review, I'm Bob Busker.